Well, hello, everyone. My name is Jenny Feng. I'm a assistant professor at the University of Louisville Multiple Sclerosis Clinic. So I'm a neuroimmunologist, and I just recently joined faculty here a couple months ago. I'm really happy to be talking to you guys about remyelination in multiple sclerosis, which I think is a really important and really exciting topic within the neuroscience and neurology realm. So I'm going to go ahead and get started. All right, so here are the learning objectives and the CME codes, which I will display throughout the talk, so you don't have to quickly write this one down, but I will be kind of showing this throughout the talk. So we're going to be understanding the multiple remyelination therapies in multiple sclerosis and understanding the mechanisms and barriers to remyelination. We're going to be talking about a couple of really exciting compounds that have been shown to have remyelinating potential that are under current investigation. And we're going to be talking about some imaging and non-imaging measures that are used in remyelination trials. And then I will end the talk with talking about the optimal clinical trial design that's suited for testing remyelination compounds. So just to get started, I'm going to talk a little bit about background for MS. So multiple sclerosis, as you know, is a chronic immune-mediated and neurodegenerative condition of the central nervous system. It's one of the most common non-traumatic causes of disability in young adults, actually. It used to be the most common, but now it's one of the most common. The onset of symptoms usually around 20 to 40 years old. We actually don't know when the disease onset it starts, but that's presumably sometimes earlier than the symptom onset. And we know that from natural history studies, we know that patients usually transition to a more progressive phenotype after 10 or 20 years of disease. The prevalence of MS about 3 to 4 out of 1,000, and it's currently about 1 million patients in the US living with MS right now, and about 3 to 4 million worldwide. And the incidence for MS, actually the prevalence is increasing, and the incidence may or may not be increasing, and that may be due to a better diagnostic criteria and also possible environmental factors. So we know that as disability increases in a lot of the neurological diseases, the quality of life goes down and workforce participation also goes down. And there's no cure currently for MS. We have lots of really good disease modifying therapies that can reduce relapses and the lesion accumulation, but we cannot cure MS. So the annual economic cost for MS, which includes direct healthcare costs and lost productivity for these young adults, is about $10 billion in the US and about $15 billion in Europe. So it is a very, a serious disease that have a lot of, economic implications as well. So the pathogenesis of MS, it was first described by the French, neurologist Charcot, who back in 1868, who discovered these characteristic sclerosing plaques in the periventricular regions and also in the pons and spinal cord. Nowadays, we know that MS lesions can also occur in the optic nerve, juxtacortical regions, cerebellum, and brainstem. It is comprised of an adaptive and innate immune response, comprising T cells, B cells, macrophages, and natural killer cells, microglia, and some others that are all responding to the initial disease initiation, which right now there's a lot of studies looking at triggers, but we don't know exactly what's that one trigger that causes disease, and it's most likely multifactorial. And also all of these immune cells also contribute to the eventual progression of disease. So currently we don't have any, disease-modifying therapies targeting the progressive course, the neurodegenerative course of disease, but lots of really good medication for the inflammatory phase. So myelin in the CNS, that's synthesized by oligodendrocytes. So the oligodendrocyte, it wraps around the axons in myelin sheath, and then each segment of the sheath are separated by nodes of Remyelination, which you can see here, and that's responsible for the fast saltatory conduction for signal along the axon. And when demyelination occurs due to acute inflammatory factors mediated by T cells, B cells, macrophages, then you have a degeneration of the myelin sheath leading to exposed axons. And when that occurs, the axons is prone to physical and metabolic damages, and that leads to eventual degeneration of the axon. So demyelination, you also can have oligodendrocyte damage and loss. And so the implication for demyelination is that first you have loss in saltatory conduction. So you have the voltage gated sodium channels that were originally in the nodes of Ranvier. They kind of spreads out through the axon. So that obviously increases energy demand for the axon. Then you have the oligodendrocyte loss that's associated with the potassium channel loss. So that leads to altered potassium transport, and that leads to energy failure as well. And then you have the loss of the physical and trophic or nutritional support by the oligodendrocytes and the myelin sheath. So like I said, you have axonal damage that are physical, that are metabolic, that are oxidative, and that leads to neuronal damage and eventual neurodegeneration. And we note that there's no right now there's no disease modifying therapies that can reverse neurodegeneration, but we do know that there's certain degree of endogenous remyelination mechanisms that are occurring, and our current thinking is that to enhance that endogenous remyelination mechanism, and that can lead to improved disability for MS patients, hopefully. And that's going to be later part of my talk, which I talk about some of these compounds that do that. Okay. So going next about remyelination. So it is mediated by oligodendrocyte precursor cells, which now I would refer to them as OPCs. So they are capable of remyelination in acute, demyelinating lesions, and also in chronic MS as well. And we know that the mature oligodendrocytes do some of that too. So so they improve, so remyelinated axons that are improved in conduction velocity, and these oligodendrocyte progenitor cells and eventual oligodendrocytes, they do provide physical and trophic support, and that can promote neuroprotection down the road. So OPCs, we know they're very abundant in adult brains, and they're early in the MS disease course. And over time, studies have shown that the OPC decreases in number. So that probably confers to a decreased ability to endogenously remyelinate demyelinated lesions over time. And there's probably some inadequate compensation of that endogenous remyelination technique because there's ongoing, in MS, there's ongoing inflammation that are chronic, and it's continuing to provide damage to the axons. So we know that the partially remyelinated lesions, they are there, but they're probably inadequate to perform the usual function that the axon needs, which results in the disability that you see in MS. So here I have two pictures showing you the partially remyelinated axons. So over the top is stained for toluene blue stain for myelin. You can see that the axonal, sorry. My mouse cursor. Okay, so you can see that's a very thin layer of myelin around these axons. So that's abnormal, and you can see the thickness kind of varies. Some are really thin, some are a little bit thicker, but there's very heterogeneous remyelination mechanism at play. And you can see there's abundance of these oligodendrocyte precursor cells here. And here is just the electron micrograph showing you the same thing, the thinly remyelinated axons that are probably not functioning as they were before the acute demyelinating event. Okay. So, there's lots of barriers to successful remyelination. So we know that the inflammatory environment that we see in MS is very hostile to that process, and the axonal damage it's also there because you can't successfully remyelinate an axon that's already been damaged, that's already been dysfunctional. So it's hard to wrap myelins around that area. And there's physical barriers, the gliosis and the cellular debris you see in acute demyelination that can impede the migration of these oligodendrocyte precursor cells to the lesion site. And then you have ineffective oligodendrocyte precursor cell function, or decrease in number of oligodendrocytes that are, maybe they're immature, or they're incapacitated cells, or there are no cells to do the remyelination. So there is a therapeutic need, which I have stressed throughout this talk. We know that we have lots of good medication that can reduce the relapse rate, reduce the lesion formation, but overall they are all still primarily targeting the inflammatory portion of MS pathology. We don't have limited therapeutic options for progressive MS. And progressive MS, we know it's the disability progression in MS is the driver for a lot of the medical and socioeconomic burdens in MS. And we need good therapies to prevent disability progression and to prevent recovery of these neurons. And so therefore, both remyelinating and neuroprotecting therapies are needed. But for the rest of the talk, I'm mainly going to focus on the remyelinating therapies because there's also tons of stuff for neuroprotection that deserves another talk by itself. Okay. So here are the available, disease-modifying MS therapies. Now we have close to 20 medications, and these are all targeting, the inflammatory component of the immune system. And there's some medications that have been shown to have some, modest effect in progression, but that's not their primary mechanism of action. Okay, so to have successful remyelination, you need operating and functional oligodendrocyte precursor cells that can eventually mature to oligodendrocytes. You need to enhance these functions and to create a favorable remyelinating environment. You need to decrease the obstacles to remyelination, for example, inhibiting some of the reactive and toxic astrocytes and microglia. And also you need to increase the axonal survival because, like I said, you can't really effectively remyelinate a damaged axon. So all of these are potential targets that are being looked into for remyelinating therapy in MS. Okay, so now we're going to move on to talk to potential drugs that have been found to show some effect. So here's a picture showing all the possible pathways that have been discovered to promote that the oligodendrocyte precursor cell maturing into oligodendrocyte process. So there's a bunch of pathways. So there for cellular division, there's the fibroblast growth factors, and you have the semaphorins, which some of them are attractants, meaning attracting the OPCs to the lesion site, and some of the semaphorins that are repellents. So we know that we should probably be blocking these repelling semaphorins and also increasing maybe some of these attractant semaphorins. That's the idea for some of the research backing compounds that do that. And we know that there's maturation inhibitors. For example, all of these pathways and compounds have been shown to inhibit that process from which an OPC becomes an oligodendrocyte. So there are lots of compounds that are being looked into to inhibit these inhibitory mechanisms. And also we have the maturation inducers, which are listed on the right side here, and there are also some compounds that are being looked at to enhance some of these functions. So overall, the overall goal is to create functioning oligodendrocytes that can perform remyelination. And we know that the direct cell replacement with oligodendrocyte precursor cells are also being looked at, but we don't know whether direct cell replacement can translate to improved function. And right now, I think the thought is to look at some of these trophic factors and try to modulate and augment their effect rather than direct cell replacement. So there's lots of ways to screen for potential compounds. So screening strategies are obviously very, very important because you want to find the cheapest way to screen the maximal number of compounds, and then filtering these potential compounds into a couple that can be brought into phase 2 and even phase 3 trials. So you want to look at the compounds that have pro-remyelination potential in vitro and in vivo. So, for example, some of these ways to screen for compounds is by using the rat optic nerve derived OPCs. So you can screen compounds this way by seeing whichever compound that can promote the cellular division and proliferation of these OPCs, and that can be potentially be used translated to a phase 1 or phase 2 study in humans. So benztropine, which is a muscarinic receptor antagonist, that was discovered this way by their effect on the rat optic nerve derived OPCs. And also you can look at mouse pluripotent epiblast stem cell derived OPCs, basically looking at whichever compounds that promote their proliferation. And miconazole, which is antifungal, and clobetasol have both been discovered this way. And another group that have been shown and like I said, looking at the OPCs and looking at compounds that proliferate these OPCs, they're medium throughput because you can, effectively screen lots of compounds in an efficient time manner. So then there comes microarrays, which is a high throughput screening method. So this group, they have generated these micropillars, which are comprised of essentially silica, and they can effectively put compounds into these micropillar arrays and look at the quantification of the myelin that are eventually generated that are wrapping around these micropillars. And you can screen for thousands of compounds this way very fast. And here's an electron microscope of the micropillars, and you can actually see a couple OPCs here. And you can see some mature oligodendrocytes here and here. So these cells eventually form myelin rings, which you can actually count and quantify to select the agent that that has the most remyelination potential. So through the micropillar arrays, Clemastine and benztropine again have been identified as potential drugs that can be used in remyelinating MS. And there are some intermediate animal models, which again are medium throughput, meaning you can only screen for a select couple of compounds rather than looking at thousands and thousands of compounds at the same time. So zebra larvafish and African clawed frog larvae have been looked at as models to test for some of these compounds. And from there, they have found that agents that are agonists to the proximal proliferator activating receptor or the SRC family kinase inhibitor or steroid hormones have been found to have remyelinating potential. And then rodent models, for example, EAE, that are also available for testing some of these compounds, but they're more for kind of in the final stage of testing right before translational research rather than for the initial screening process because it is very costly and time consuming. And over here it shows you the zebrafish larva, in which the investigators have shown that by applying certain compounds, they can increase the number of oligodendrocyte cells, which it actually can physically count here along the spinal cord of the larva. Okay, so despite the numerous potential compounds that have been identified in these medium and high throughput screening methods, only a few has been tested in phase 2 and possibly phase 3 clinical trials. And I have listed a couple of mentions worthwhile here. And I didn't include any of the compounds that are generated primarily for neuroprotection because that's another set of compounds. So these all have been shown to have remyelinating potential. And I have listed their mechanism of action here and the patient population that it was tested on and the results. And I will go into detail with each one of these compounds in just a little bit. So Clemastine, it's a antihistamine agent that's a H1 receptor blocker. So it promotes endogenous OPC function, and it has been tested in a trial called Rebuild, which is a single center randomized placebo-controlled double-blind phase 2 clinical trial. So in there, they have looked at 50 patients with chronic optic neuropathy in the setting of relapsing MS, and the primary outcome was to look at improvement in visual evoked potential latency. And the result was positive in that they have shown some improvement in the visual evoked potential latency in the Clemastine group, both on cross over analysis and on post hoc delayed treatment analysis. And there was a non-significant positive trend in the clinical outcome measure. So for people with optic neuropathy, you'll be looking at low contrast letter acuity, which is a clinical measure. But there was a non-significant positive trend with Clemastine. So the trial in acute optic neuritis with Clemastine is currently ongoing, and also then the primary outcome for that trial is also to look at the visual evoked potential latency improvement. And Opicinumab, which is a newer compound. It's an anti-LINGO monoclonal antibody. So LINGO stands for leucine-rich repeat and immunoglobulin domain-containing neurite outgrowth inhibitor receptor interacting protein 1. So it's a mouthful. So I'll just be referring them to as LINGO for the rest of the talk. So it is an adhesion molecule that inhibits myelination. So the idea is that we're creating this monoclonal antibody that blocks that in LINGO1 function. Is it has been shown to promote remyelination in animal models. So RENEW is a phase 2 clinical trial that is placebo-controlled and double-blind that tested Opicinumab in 82 patients with acute optic neuritis. And the primary outcome was to look at improvements in visual evoked potentials. They have found that Opicinumab improved the visual evoked potential latency in a per protocol analysis, but in the intention to treat population analysis, they did not find any significant benefit. However, it was further tested in the phase 2b clinical trial, which is the Synergy trial that looked at 400, it's a larger trial, so looked at 419 relapsing remitting MS patients or patients with secondary progressive MS. They were randomized to Opicinumab and or placebo, and the primary endpoint was to look at actual disability improvement, which is a clinical outcome measure. And over here, they did not find any linear dose response because they tested several, potential dosing for Opicinumab, so it did not find a significant linear dose response. However, they did find that there was an inverted U-shaped response. So the most benefit we're seeing in the group that received the 10 milligram per kilogram Opicinumab dose, and in the group that received the 30 milligram per kilogram Opicinumab dose. So, and also in subgroup analysis, they discovered that patients who are younger than 40 years old, who have shorter disease duration, so less than 8 years, and patients with MRI markers that indicated more preserved cerebral reserve, so patients with higher baseline T2 myelin content and patient with higher, better structural integrity at start, those patients benefited more from Opicinumab rather than the patients who are in the opposite end of the spectrum. So overall, this is providing some encouraging results for the potential role of Opicinumab. We just need to find, the correct dosing and to test it in the correct population to see if there's any remyelination potential that can translate to clinical measure improvements. And now moving on to Temolizumab, which is GMB-AC1. That's a monoclonal antibody against the human endogenous retrovirus, HERV, envelope protein. So this protein was found in higher levels in MS brain lesions and also in MS patients' cerebrospinal fluid and blood mononuclear cells. And it was proposed to promote OPC differentiation by inhibiting the immune activation pathway. So this compound, GMB-AC1, was tested in a trial called Change MS, which is a randomized placebo-controlled double-blind phase 2b trial in which they looked at 270 patients with relapsing MS, and they found that there was no change in the inflammatory disease measures. So, they didn't see any improvements in the relapse rate or the lesion outcomes. But they did find that there was an increase in the MTR signal, which is used to look at myelin, and also they found there's decreased T1 black hole burden, and also decreased cortical and thalamic atrophy rates in the treated group. So this suggested that Temolizumab may have a potential role in remyelination and neuroprotection, and so that would support its in testing Temolizumab in the larger trial. And another compound called GSK-239512, and that's a histamine H3 receptor blocker that actually penetrates the CNS. This has been found to have some remyelinating potential because they can promote OPC differentiation process, into mature oligodendrocytes. So this was tested also in a randomized parallel group, placebo-controlled double-blind phase 2 trial in which they enrolled 153 relapsing MS patients. The primary outcome was to look at the changes in the MTR, which, like I mentioned, is the indirect marker for myelin. They look at the MTR values and lesions, and they have found that this compound had a positive effect on MTR change, favoring this histamine H3 receptor blocker. So that also suggests a potential role in remyelination that needs to be further tested in a larger trial. And high-dose biotin, which we actually just had a recent journal club on. So this is a vitamin B7. It doesn't have direct remyelinating potential because it's mainly a neuroprotectant agent, but people have found that it may stimulate oligodendrocyte function and myelination. So it was tested in the MSSP SB1 trial is a randomized double-blind placebo-controlled pivotal trial looking at 154 patients with progressive MS who were given high-dose biotin. So that's up to 300 milligrams a day. They have been found to improve disability measures, which are captured by EDSS, and then subgroup analysis shown that visual acuity was also improved in some of the patients. However, the more recent trial that just came out, which is the SP2 trial, it's the even larger trial, phase 3, even larger trial of 642 patients with progressive MS who were given high-dose biotin versus placebo. And this trial, unfortunately, did not show any confirmed disability improvement. In addition, it was shown to have increased adverse effects because high-dose biotin can certainly influence with laboratory abnormalities leading to possible iatrogenic injuries. So because of this trial that recently just came out, we are now discouraging clinical use for high-dose biotin in progressive patients because it has not shown to have any significant clinical benefit, and there's a risk for increased adverse effects. And simvastatin, that's a HMG-CoA reductase inhibitor, traditionally used in patients with hypercholesterolemia. It has been found to actually also stimulate OPC survival rate and also their differentiation towards mature oligodendrocyte. Again, it's not a direct remyelinating agent, but it has been found to have remyelinating potential. So in the SimCombin trial, which is a high-dose simvastatin, 80 milligrams, and that were given to patients who already were on some interferon beta therapy. So it was tested as the add-on therapy, and they enrolled 307 relapsing MS patients, and they did not find any significant effects on the annualized relapse rate. But in the MS-STAT, which is a separate trial, a phase 2 trial looking at high-dose simvastatin compared to placebo in 140 secondary progressive MS patients, they found that there was a significant reduction in annualized brain atrophy rate in the treatment group. So it was a small effect, but it was significant in delaying disability worsening. And also it has improved in patient-reported outcomes. So the effect, and there's a separate study that looked at, why does simvastatin, have this kind of effect? And it was shown that the effect on clinical and MRI measures were independent of its effect on cholesterol level. So possibly through another mechanism of action that is promoting, remyelination. Yeah. So I forgot to mention the MS-STAT2, which is a follow-up trial looking at simvastatin and remyelination is underway. And another experimental therapeutic that I should mention is mesenchymal stem cells. So these are pluripotent, non-hematopoietic precursor cells, which are obtained from bone marrow or adipose tissue. And they have been shown to have various roles, those not just one, but various roles in enhancing repair and also in neuroprotection. And people thought we think it's possibly through the secretion of trophic factors rather than direct cell replacement. So mesenchymal stem cells has actually been tested in multiple small clinical trials in MS. So the sources for the cells vary in among these trials. So some trials use autologous cells, some trials use allogenic umbilical cord derived cells, and then some trials use placenta derived cells. And the administration route also varies, so it can be given intravenously or intrathecally. And overall, all of these trials are mainly geared towards looking at safety and tolerability, and it have been found to be relatively safe and decently tolerated. And in the secondary and exploratory outcome measures for these trials have found that there is a small positive effect on clinical and MRI measures. So that remains to be further elucidated in larger trials as well. So here's a list of all the drugs that are coming down the pipeline. So there's a couple new trials that have been completed on new compounds. So beta-roxetine, which is a retinoid X receptor gamma agonist that have been trialed on relapsing MS patients. Domperidone, which is a compound that increases serum prolactin, that have been also evaluated in phase 2 trials in relapsing MS and also in progressive MS. An anti-semaphorin 4D monoclonal antibody that have been looked into and completed a trial in phase 1 in MS patients. So all of these results are probably going to be coming out in the next couple of years. So it's very exciting. And there's also ongoing recruitments and planned start for a bunch of other compounds, which I'll briefly mention here. So Opicinumab, like I mentioned, this is a phase 3 trial looking at the efficacy of Opicinumab as a add-on therapy to disease-modifying therapies in relapsing MS. So that's very exciting. And also MSStat2, which I mentioned before, is Simvastatin. Is looking at disability progression in secondary progressive MS. And then the autologous mesenchymal stem cell IV infusion trial, the MESMS trial, is looking at the safety and efficacy of these stem cells in relapsing MS and also in secondary progressive MS. And I listed all their NCT numbers here if you want to take a look for more detail. And then non-pharmaceutical compounds, transorbital electrical stimulation, that was shown to possibly induce repair through electrical stimulation, and that is being looked at in acute optic neuritis in 2 different trials. And nanocrystalline gold, that has been shown to alter myelin gene transcription, that's being looked at in chronic optic neuritis. And bezadoxafen, which also supposed to have is an estrogen receptor modulator, supposed to have remyelination potential, being looked at in chronic optic neuritis. Quetiapine, which is the antipsychotic drug, people are looking at an open label dose finding trial in relapsing and progressive MS. And then thyroid hormone has also been implicated in the remyelination pathway. So there's another trial, a safety and dose finding trial, looking at a liothyronine T3 compound in MS as well. And lastly, testosterone has been found to augment the remyelination process. So that is being looked at in men with relapsing remitting MS in a different trial. So all of these are very, very exciting. So this is the focus of the MS research world right now, to look at remyelinating and neuroprotective agency therapies. So this is be on the lookout for the results for these trials in the next couple of years. All right, so the second half of my talk is going to focus on, so now we have all of these compounds. How do we accurately measure remyelination? How do we know these compounds are effective? So we need accurate ways to look at myelin so that we can see potential drug responses, and also for a deeper understanding of the pathophysiology involved in remyelination. So measuring myelin, we need in vitro measurements. Historically, that's been done to look at myelin histochemical staining. So obviously, that is not feasible for clinical trials. So the optimal outcome measure for remyelination in clinical trials should strive to be pathologically specific to myelin, to be biologically sensitive to the changes in myelin content, and to be feasible and reproducible so that it allows for testing in multi-center trials, for potential phase 2, phase 3 testing. And also they should reflect meaningful changes in clinical function, because, all the remyelination, it may not be clinically significant, and that won't translate to any regulatory agency approvals for any drugs. And also these measures for remyelination should respond to treatment so that we can effectively and accurately measure treatment responses. So there are many phase 2 trials that have utilized electrophysiologic measures, for example, the visual evoked potential and or advanced MRI measures that are looking at remyelination. And also there's phase 3 pivotal trials that are being looked into, because all of these compounds, they must demonstrate clinical efficacy, because that's what's needed for eventual FDA approval. So Evoked Potentials is a non-invasive in vivo electrophysiologic measure that looks at the response of for various myelinated tracts. So demyelination, we know that results in abnormal nerve impulse generation, and therefore conduction deficits can be detected on various evoked potentials as delays or blocks. So there's visual evoked potential, somatosensory evoked potential, brainstem auditory response potential, and also motor evoked potential. Those are all possible electrophysiologic measures that you can test for. So it's relatively easier to administer, and it's pretty reliable, pretty sensitive, and it's relatively cheap. So if you want to consider using this in a large clinical trial where you're recruiting hundreds of thousands of patients, this is a good outcome measure to use. However, only select lung tract can be assessed. For example, the optic radiations, the cortical spinal tract can be assessed. This is not for assessing some of the complex intracranial pathways. And over here, this is just showing you how the visual evoked potential is done. And you're looking at the P100 wave, and you're looking at the latency between this wave and the onset of the stimulation. So any improvement in the latency in a demyelinated person is shown to have remyelination potential, because you're improving that latency. So MRI techniques, there are conventional MRI metrics such as T1 or T2 lesion burden that have been traditionally looked at. Contrast enhancing lesion numbers have been traditionally looked at. So they're probably better suited for relapse-related outcomes, because they're more accurately reflect inflammation. So they only weakly correlate with disability outcome measures, so that's not ideal for remyelination trials in which you want to demonstrate improvements in disability. And then T2 signal, the T2 lesion signal, is not specific to myelin, so it's not a particularly pathologically sensitive or specific measure. So there are a bunch of advanced MRI techniques that are non-invasive, and they either directly or indirectly assess myelin or myelin integrity in vivo, and they have improved sensitivity and pathological specificity, which I will go over in the next couple slides. So magnetization transfer imaging, which I already mentioned in a couple previous slides. So this measures magnetization transfer ratio between the free protons that are floating in the CSF and restricted macromolecule bound protons. So basically in somebody with lots of myelin, you're going to have a higher MTR ratio because these protons are bound to the macromolecule, which is myelin fat. And then in somebody who have lots of demyelinated lesions, so within these lesions, you might see lower MTR values because the myelin the integrity is disrupted and these protons become unbound. So you have an increase. You have a decrease in the MTR number. So it is generally considered to be a myelin marker. Like I said, decrease in demyelinated lesions and increase when it's remyelinated. So it's responsive. So you can show treatment response using MTR. And it has been used as a secondary outcome measure in several of the remyelination trials, and as a primary outcome measure in the GSK, which is GSK trial, and the beta-roxifene trial. So like I said, it is considered a myelin marker, but the specificity is not 100% because it can be affected by inflammation changes, tissue edema, and also axon loss. So there are a couple related magnetization transfer imaging techniques that supposed to improve the specificity that are being validated for as trial outcome, potential trial outcomes. And here's a picture of basically what MTR looks like. So this is a T1 post-contrast imaging showing that there's two demyelinated lesions right here with acute contrast enhancement. And this is MTRA enhancement, which you can see is decreased, though this darker signal value in those areas. And then, and then 39 months after enhancement, you can see that one of the lesions, actually the values increase almost back to that of the normal appearing white matter nearby. And then in this lesion right here, the value actually decreased further. So that's showing you that there's a heterogeneous response to remyelination. This lesion has recovered quite well, so the remyelination was successful here. Meanwhile, in this lesion, there's continued demyelination, there's likely some chronic permanent axonal loss in that region as well. So MTR, you can see, is a great outcome measure to look at myelin. And then there's more specific measures. Well, here's the myelin water imaging, which derives the myelin water signal, which is known to be short, to have a short T2 relaxation time because they're bound within the myelin bilayer. And they're looking at the myelin water imaging looks at the myelin water fraction of these short myelin water signal to the total water signal, which are presumed to be longer. So myelin water fraction can be decreased in lesions in which you have demyelination, and also in normal appearing white matter as well in the MS patients. So it is specific to myelin and can show treatment-related changes in trials. Some groups are looking at alemtuzumab and ocrelizumab and looking at some exploratory measures, looking at using myelin water imaging, and have been shown to have treatment related response, positive treatment related response in these trials. And also the Hope ring myelin water fraction is being used as a secondary outcome measure in the Clemastine trial. So that's also very interesting. So the one issue with myelin water imaging is that it requires very long acquisition times, and sometimes there can be incomplete brain coverage. So related techniques looking at myelin water imaging that are being optimized to cover some of these issues, and that is being validated too in some of the studies. So diffusion tensor imaging is another advanced MRI technique that basically measures the Brownian motion of water molecules. And over here, I have a little picture showing that myelin, when you have myelin damage, the water molecules that typically floating along up and down the axon are now being diffused outward because of demyelination. So you have an increase in radial diffusivity in these demyelinated areas. So we know that increased radial diffusivity is thought to reflect, damaged or decreased myelin integrity. So in lesions, in MS lesions, you will have an increase in radial diffusivity number. And here is a study that I did actually during my residency, looking at diffusion tensor metrics in MS patients who, this is secondary progressive MS patients who received mesenchymal stem cell transplants. And you can see in this lower panel here, there's the lesion radial diffusivity actually decreases right after the transplant, but then remains stable. So that possibly can be shown to have response to treatment by looking at the radial diffusivity values. So one caveat is that the diffusion tensor imaging is limited by fiber tract orientation and the axonal density. So if you're not looking at a specific long fiber tract, for example, the optic radiations, the corticospinal tract, if you're just looking at the area in the brain, the crossing fibers with different orientations can affect your diffusion tensor imaging value. And also if you have an area with low axonal density, that can obviously affect your diffusion tensor imaging value. So then this leads to another diffusion Tensor imaging measure, which is the neurite orientation dispersion and density imaging, or shorthanded as NADI. So this one is a technique that quantifies the neurite density and also the spatial orientation of each neuron. So so it's a little bit more easier to test for demyelination within specific neurite rather than being dependent on axonal tract orientations. So we know that orientation dispersion index is decreasing MS lesions when this imaging technique was used to image MS patients. And then outside of MRI, so you have magnetic resonance spectroscopy, which is a metabolic imaging technique using MR that detects cellular metabolic changes. And we know that some of the measures, for example, choline changes can be seen in demyelinated lesions. However, MRS lacks spatial resolution, and also we don't really have a metabolite that's specific to myelin changes yet. But this is something to be considered for the future. And then positron emission tomography, or PET scan. So this is a potentially quantitative myelin imaging technique that can be done in vivo. So myelin binding radio tracers are actually actively being developed right now to be used in human subjects. So this is a potentially very, very specific imaging measure that may be helpful for future studies, but it's not available right now because we don't have a validated myelin binding radio tracer yet. So last part of my talk is going to be briefly discuss the clinical trial design that are needed to test remyelination. So many trials that I have mentioned before are short-term parallel group trials, basically looking at treatment compound versus placebo. Although from these trials, we don't know the duration of benefit for these treatment compounds, and these trials, and they often require a large number of patients to be enrolled to be able to detect the small changes that may be seen in some of the outcome measures. So crossover design has been proposed as a good design to test in remyelination, because you have an increase in statistical power, so therefore decrease in sample size requirement, and also you can evaluate the possible duration of benefit, because you have these patients. So group 1 randomized to drug, group 2 randomized to placebo. You monitor them for usually on an average of about 6 months or so. Then you have crossover where the group 1 now receives placebo and group 2 now receives the drug, and then you monitor them for another 6 months. So over here you have a extended duration in which you can monitor for drug benefit even after patients taken off the drug. And also the crossover design allows each patient to be their own control. So this is how the statistical powers increase. So you don't have to recruit as many patients, which is great for some of these very expensive trials. So this crossover trial designs is most likely for these remyelinating compounds. The patients are going to be allowed to be on some kind of MS platform therapy, like one of the disease-modifying therapies. Although it can be complicated if you're testing multiple drugs or different doses, but for a single drug with a known effective dose, this can be a really good design. And also another method has been proposed, which is the addition of a run-in period prior to randomization, because we know that certain individuals, they have very different endogenous remyelinating mechanism. So some patients may remyelinate fast or more effectively compared to another patient. So by adding a run-in period prior to the patient being randomized for drug or placebo, you can factor this into your final analysis to account for these individualistic differences. And also there are a couple different model systems that can be used to test for remyelination. So anterior visual system, which is optic nerve. So essentially you're evaluating the effect of the whichever compound you're testing on improvements in whether in VEP or also in optical coherence tomography, looking at neuronal loss. So these are all this is a very good system because optic neuritis is very common in MS, and the optic nerve is relatively easy to have access to in terms of testing. And also it has visual function testing correlates clinically, and also patient-reported outcomes to MRI correlates. So it's a pretty good system. Also, one caveat is that whether benefits seen in the optic nerve can be translated to benefits in the rest of the CNS. So that remains to be further elucidated. So the optic nerve has been used in Opicinumab trial, which I have mentioned previously. So the Opicinumab phase 2 trial, the ReNeu trial, looked at recovery from acute optic neuritis and VEP improvement. And the Rebuild trial looked at Clemastine and VEP improvement in patients with chronic optic neuritis. So obviously this is something to consider if you wanted to design a trial, but you have to keep in mind whether you want to recruit acute optic neuritis patients or chronic optic neuritis patients, and which outcome measure you're going to use. And then the spinal cord is another system that you can use to measure remyelination, because there's good electrophysiologic measures, the SSEP, the MEP. There's MRI and clinical and patient-reported outcome correlates, and the spinal cord changes usually have a stronger correlation with disability compared to brain MRI changes. So, however, there's a heterogeneity in the disease pathology that can affect the spinal cord, and the imaging measures, they're not exactly optimized and validated for the spinal cord, especially some of the advanced MRI measures. So, so spinal cord, while it's fine theoretically, but there's a lot of technical and logistic issues to be sorted out before this can be more effectively used for testing remyelinating compounds. Then you have the lesional measures, which can be detected using advanced MRI techniques that I have mentioned before. So you can look at the recovery for contrast-enhancing lesions or improvement in the chronic lesions. Those are all fine. However, there's a poor clinical correlation though, because we know lesional measures in the brain don't correlate as well compared to the spinal cord lesions. And also there's a lesion pathology heterogeneity that needs to be that can potentially affect your outcome measure. So that's something to be considered. And then clinical disability, for some trials, they decide to just directly go to a phase 3, a large phase 3 trial looking at the benefits in clinical disability. So this is necessary for eventual regulatory agency approval, like I mentioned before. And so clinical disability, you can use EDSS scores, you can use the multiple sclerosis functional composite scores, and there's also validated electronic adaptation of this measure. And also you can look at patient-reported outcome measures. So all of those are fine. The only caveat is that some of the remyelinating compounds, they have a small or mild benefits that sometimes don't exactly translate to clinical benefit. So, and then again, you have to consider target patient population, whether you're testing, relapsing MS patients or progressive MS patients, patients, with various remyelination potential, patients who are on different types of DMTs, and patients' disability levels. So all those can affect your outcome measure. And then you have to make sure you choose the correct model system to measure remyelination, choosing the correct metrics, and choosing appropriate myelin-dependent clinical outcome. So rather than EDSS, the walking speed, processing speed, and hand function speed may be more myelin-dependent because these are all carried by large myelinated axonal tracts. So they may be more sensitive to differences with remyelinating compounds rather than EDSS. And also you have to consider your treatment target. Are you looking for improvement in these measures, or are you looking for delay worsening in these measures? So these are something to be considered. So overall, I think I made it just on time. So on conclusions, basically MS, like I said, most common causes of disability. We have lots of really good drugs that can treat the inflammatory portion of MS, but there's a major unmet need in progressive MS, in which we need really good compounds that can target neurodegeneration. So remyelinating compounds, whether via either direct or indirect pathways, have been identified. Actually, we have more than enough compounds that we can test for. And there are also some experimental therapies that are not drug-based that have been shown to maybe helpful. And they're all in various phases of clinical testing. So this is a very exciting decade for MS research in this aspect. And testing remyelination drugs in clinical trials needs strategic planning so that you can that you're getting what you're tested for, and that results in the remyelinating potential translates to clinical benefits. So future directions, like I said, more compounds are coming. They're identified in the high throughput screening methods. So there are more and more compounds becoming available to be tested for in clinical trials. And also some of these mechanisms that we're looking at to measure remyelination that may give us further understanding of the remyelination mechanism of action in these compounds and also in patients themselves. And there's development and validation of new and sensitive and specific outcome metric, especially in the imaging realm. And also we're looking at very exciting and clinical trial design that may be more optimized for remyelination testing, remyelination drug testing purposes. So I would like to conclude this talk by thanking my mentors at Cleveland Clinic, and they've taught me everything I know about MS, and Dr. Kara Remmel for being such an inspirational person when I was here as a medical student, and also for hiring me on board as faculty. And my UofL MS clinic team, Drs. Robertson, Dr. Michael Sweeney, Sarah King, the APRN, Jacinta Locker, the MS coordinator, Tammy and Rosalind, the MS RNs, and Emily Evans, the MS pharmacist, who we all work together in concert to improve MS care for a lot of for our patients. And obviously the MS patients I need to thank too, because without them, none of these trials are possible. And also they're the ones that are providing the motivation for us to work harder and work smartly to find a cure for MS in the future. And I can be reached in, either in the MS clinic, or you can find me on Twitter, and you can also email me if you have any questions. I believe there may be just a couple minutes left for questions, so I'm happy to take any, and also happy to discuss with you, either in person or after this talk.
Hey, Dr. Feng, this is Nick Kuipers. Can you hear me?
Yes. Hi.
Hey, it's good to see a great talk. Thank you so much. So I think you made a comment a little bit earlier in the talk, and it was about the contribution of OPCs as well as mature oligodendrocytes to remyelination.
Yeah.
And as I look through recent literature, specifically like the Jonas Treason lab from the Karolinska Institute, which now has been replicated over the past 5 or 6 years, and maybe 5 or 6 other institutes as well, really looking at in humans the difference between mice and humans or any other preclinical model in humans and how remyelination is accomplished in MS patients seems to be primarily driven by the mature oligodendrocytes over the OPCs. Yeah. And I'm curious to hear your thoughts on, we've been kind of barking up this tree of trying to enhance OPC specific or centric remyelination for so long, and we still have no drugs in our hands available to the clinical market. Do you think that this could be an underlying issue, as maybe we're asking some of the wrong questions?
Yeah, obviously the remyelination mechanism, and there's lots of pathways involved, and there are lots of cell types being involved. So right now, the more information is obviously better, and I think the whole MS community is continuing to learn, as you've seen from some of the failed trials, on what works and what doesn't work. So the mature oligodendrocytes obviously is a potential target, because a lot of because those are the cells that are eventually myelinating these axons. And the question is whether, the mature oligodendrocytes themselves are, in some of these MS patients, whether they have functional mature oligodendrocytes or whether they have enough of them in number is the question. And should we augment these mature oligodendrocyte function versus, direct cell replacement? That's, something of obvious discussion. And I think both of these pathways in the OPCs to mature oligodendrocytes and malignant oligodendrocyte function thereafter, they all are potential good targets. So I don't think we should ignore one or the other. And I think they're just a matter of having the right people focusing on each of the pathways. Any other questions? Alrighty, well, thank you guys for attending this grand rounds. And like I said, feel free to reach me anytime. I'm happy to discuss anything about MS or remyelination or anything else. Alrighty.